Welcome, everyone. Thank you for joining us today. My name is Melanie McGacken, and I'm delighted to welcome you on behalf of the Rutgers Community Living Education Project team, often referred to as CLEP. Today's webinar features Dr. Jennifer LeComte and Dr. Andrea Iannizelli from the Rowan-Virtua Regional Integrated Special Needs RISN Center. Today's session will explore how food, movement, mindfulness, music, and art can be used to support healing and well-being. We'll also learn the value of a proactive healthcare model and the power of teamwork, specifically how advocates, families, caregivers, and communities can collaborate to foster a culture of wellness. So whether you're here as an advocate, a family member, a professional, or someone just personally interested in these topics, today's session will offer practical tips that you can integrate in your life or your work. Before we get started, just a few quick tips. Today's webinar will absolutely be recorded, and a link to the recording will be shared with all registrants by the end of the week. We welcome you to introduce yourself using the chat feature on your Zoom control panel and let us know where you're joining from if you're comfortable. We are here to learn from each other, so if you would like to share a valuable resource that is topic specific with other attendees, please feel free to do so using the chat feature, again, on your Zoom control panel. If you joined us before, you know that we love to keep these sessions interactive. So if you have a question during the presentation, please drop that question using the Q&A box, and we'll address as many as we can during the Q&A segment at the end of today's presentation. So now it's my pleasure to welcome two experts who've dedicated and really committed their life to our community. Please give a warm virtual welcome to Dr. LeComte and Dr. Iannizelli, whose guidance and wisdom will no doubt elevate today's discussion. Welcome.
Thanks for having us. So I'm Andy Iannizelli. And I'm Jen LeComte, so you know who each of us are. Very different, but have very similar approaches to being proactive about wellness. And since we came together, really have synergized that opportunity. And again, we don't think that this is exclusively for people with intellectual and developmental disabilities. We really think that empowering caregivers to their own wellness approaches really will make the wellness of the people that we take care of even better. And so that's what we're going to talk about today. And so we're hoping that we can get a lot. We're going to make sure. Oh, you know what? Give us 1 second to get on the right slide. So we're going to talk about proactive approaches to healthcare. The reason why we have to talk about them is because, unfortunately, in our healthcare system, there are a lot of barriers. We're not going to talk about all the barriers. You all know them, but part of our approach especially is addressing the emotional and behavioral barriers in order for our patients to get better access to healthcare, and for you as advocates to utilize some of those approaches. Because here's what really happens in healthcare. It's really scary. Our patients show up in our offices and they see all these scary things. And we as healthcare providers, so I have to own that, we approach a lot of this need for getting the data point in as an emergency, and don't actually give the time and space that we need to in order to allow our patients to access healthcare so that it's not so scary. And so those are the approaches that we really want to talk about. We absolutely believe in traditional medicine and want to make sure that we do make sure that our patients get all the same access to routine preventative healthcare in the way that they need to receive it. Everyone needs a reproductive health exam. Everyone needs a mammogram and a colonoscopy. But they aren't all emergencies. And the reality is, even with the traditional medicine, we can't always access the answer in our traditional medicine approaches, especially for our patients with different abilities. So we're going to introduce you to some of the other aspects that we include in our patients for when they're going to come to our office. So As Dr. LeCompte mentioned, we 100% embrace traditional medicine, and traditional medicine is medicine, the practice of medicine as we know it in this country, in the United States. But there are some buzzwords out there that some of you may have heard of, including holistic medicine, complementary medicine, alternative medicine, functional medicine, and some of them mean a little bit of the same things, and some of them mean a little bit different. There are some differences when it comes to the nuances. So traditional medicine, again, it's probably the medicine that we all grew up with. You have a symptom, you go to the doctor treats the symptom. Functional medicine, a little bit, actually a lot different. You have a symptom, you go to the doctor, and instead of saying, well, let's treat your symptom, a functional medicine specialist will say, well, let's do a deeper dive. Let's get to the root cause of the symptom and treat the underlying condition that's leading to the symptom in hopes of a longer term fix rather than a short-term fix, or rather than just putting a Band-Aid on the symptom. Then there's holistic, complementary, and actually alternative medicine as well. And what those include are practices that aren't necessarily mainstream. Well, functional medicine isn't necessarily mainstream at this point either. For us it is, but not for everyone else. And so those can include things like using essential oils, using nutritional supplements, using massage or acupuncture, Reiki, things of that nature. So things that modalities that traditionally haven't been purported to be science driven, but we know anecdotally that it does work for people. So with that,
yeah, we're really trying to also improve access to care, not only with those for traditional, especially for traditional medicine, and even how we administer a vaccine or how we look into someone's ears. We recognize that our patients actually they probably love technology more than we do.
Yeah.
And so having some of these other technologies in our office space to access traditional medicine, like getting a blood pressure cuff, which can be scary, accessing getting a blood pressure, even getting a weight for patients who use technology, like having a wheelchair scale. So some of these things can be very easily accessed in other traditional medicine offices. So we would encourage any one of you to ask your physicians if they don't have access to these very basic tools that can make an office visit easier and get the data points that we all need as physicians, like a weight, like making sure that everyone gets their vaccines that are appropriate for them, like getting an EKG to make sure that the medicines that we're prescribing are safe for them and they're not causing harm, without putting stickies all over someone's body, which we know our patients who are neurodiverse have some difficulties with. Even just holding their fingers for 30 seconds might seem really hard, but we've been very successful in doing this, but more successful in accessing some fun things to take the deeper dive.
So what we do at RISN Center is, again, we embrace traditional medicine, and we'll start off, if we've got someone who comes to us with a concern, we'll start off with what we call a traditional medicine workup. A lot of times though, that isn't really fruitful. Either their labs will all be normal, or maybe there are some abnormalities that don't really explain what we're seeing, what the caregivers are seeing. And it's like, boy, have we left any stone unturned? There's got to be something else. And we hate saying, I don't like the word hate, but we hate saying, well, we have nothing else to offer you. Sorry, we've done a good workup. There's nothing else. We don't know what's going on. We don't say we don't know. We say we don't have the answer yet, but we're going to keep looking. And so that's when we would move to the next step in the workup, which we call a deep dive workup. And that can include functional medicine labs. And functional medicine labs might be doing some stool testing to see what the bacteria and the gut looks like. Might be doing some urine testing to look for different organic acids. Could also be doing some mouth swabs for things like pharmacogenetics testing. And what pharmacogenetics testing does is it looks at 24 different genes that are responsible for how our bodies
absorb, metabolize, utilize, process different medications. And so then we can look and see, based on your unique genetic makeup, these might be the medications that are best for you. So rather than a shotgun approach, we're able to hone in on using a more scientific approach to prescribing medications. We also do genetic testing. There have been a fair number. We actually are in the middle of doing a retrospective look at, of all the patients that we've done genetic testing on. We started using this test a year ago. How many have had significant positive findings, meaning findings that actually have affected how we manage the patient? And it's a little less than half, but it's up there. It's a lot. And a lot of people have had genetic testing. Oh, we had genetic testing back in 2005 when my kid was diagnosed. Well, guess what? A lot's changed between 2005 and 2025. We're much more sophisticated now. So we do genetic testing, which is covered by Medicare and Medicaid, even if it had been done in the past. We also, in our deep dive workup, we actually, not even in our deep dive workup, at our initial patient visit, we ask about food preferences, sleep habits. Are they having a hard time getting to sleep? Are they having a hard time staying asleep? Do they snore? Do we need to do a workup for sleep apnea? So we just try to peel back the layers of the onion to try to get a better picture of what's going on with each of our individuals.
And what we do know is that the morbidity and mortality of patients with intellectual and developmental disability, unfortunately, is higher or lower, I guess, if you say. Our patients get sicker and die earlier because we don't give them access to routine preventative health care, and we don't do the deeper dive. For us, we all, in traditional medicine, we use a lot of risk models that our patients don't fit in, or we have to wait to kind of use them. So just give you a typical example. When we do cholesterol testing, we screen everyone for cardiovascular risk, but we can't use our risk models until they turn 40. Well, if our patients are at higher risk for dying earlier, then we want to know earlier what's happening with them. If we wait to use our risk model, age 40, we may not be able to intervene earlier. And a lot of times our interventions earlier are lifestyle changes, which is why food and sleep are part of that. So, waiting around to have someone get diabetes, or using functional medicine approach and looking at insulin levels, or looking at the cardiovascular risk numbers to be preventative earlier, is what we really are hoping to use when we do these deep dives, which really have become our basic approach to our patients. Sorry.
We have dual screens here, dueling
We're playing with both of them. So as I hit them, so we have had the privilege of receiving a HRSA grant. So that's from the federal government. I know everyone's concerned about where we have access, and we've been able to secure funding through HRSA to teach more of our primary care trainees. That's med students, residents, PAs. We have a new PA school coming here about caring for people with intellectual and developmental disabilities. And we've developed 5 themes that really are a wellness approach, which is already our core approach to humankind, really, not just people with intellectual and developmental disabilities. But the 5 themes that we are working on, and we're currently in year 2, are food is medicine, movement is medicine, art and music are medicine, mindfulness is medicine, and medicine is medicine. So again, we very much support the traditional approach to medicine and prescribing medicines. But what we also know, both from our geriatric population as they age and our patients with intellectual and developmental disabilities, we overprescribe medicines for a lot of our patients. When we see behavior change, we put a medicine on top of it. And with these alternative proactive approaches to medicines, we want to take back that and approach and ask the why question more and more and more, so that we're not just adding on, and that we can actually just get back to lifestyle management.
So you know, with all of our clients at RISN Center, all of them in some way, shape, or form have some type of neurologic issue, even if it's not evident, like not everyone has seizures, not everyone has autism, but everyone has some type of impairment with how their brain and their bodies communicate with each other. And we know in this context that food matters. So the brain is our most energy hungry organ. That's why when you hear of people who have hypoglycemia, right, when their blood sugars drop low, they can have problems with their brain. Their brain needs that constant energy. Even when you're sleeping, your brain needs energy. And good, bad, or ugly, the brain is incredibly susceptible to foods. Whether those are good foods, our brain is susceptible. Our brain can be happy with good, healthy foods. Or if it gets bad, ultra processed foods, the brain responds to that as well. So it's a product of its environment oftentimes. And we know that ultra processed foods, and what I mean by ultra processed foods is if things in general, if things come in a bag, a bottle, can, or cans, any type of packaging, if they're not sold the way that God created them, then that in general is ultra processed. Now, do mini carrots come in a bag? They do. So, you know, just a rule of thumb. And ultra processed foods count for 67% of the calories that are consumed in the general population. I would argue, we don't have any studies, but I would argue that in our population that is incredibly dependent on sensory issues, and they reject oftentimes healthy foods, I would venture to guess that in our population, it's even higher than 67% of calories consumed. And we know that a poor diet can lead to issues. What I call it is rusting. I liken it to rusting within the bodies. Inflammation, oxidative stress. To me, that's kind of like rust, not just inside our blood vessels, but inside our brains, in our joints, every aspect of our bodies can be affected by this. And then we also know that ADHD, autism, depression, bipolar, anxiety, OCD, these also can be reflective of a poor diet. I'm not saying a poor diet causes these. I'm saying a poor diet can affect our brains, and our brains are intimately involved with all of these diagnoses, and a poor diet can exacerbate the symptoms, can exacerbate the behaviors, can make things worse.
Yeah, and the reality is there's a big bias here, and a lot from the medical community that make assumptions that people with intellectual and developmental disabilities, well, they can only eat chicken fingers and French fries, right? And they actually, you know, we've heard this bias from our physicians, and we want to equally, you know, even in some of our community providers, you know, recognize that this is a big reason for why. So while we want all of our families and patients to be interacting in the community, only interacting in the community to access these ultra processed foods certainly isn't the ideal way. The other reality is that because of some of our neurodiverse patient population, consistency is really important. So when you get a strawberry from nature, sometimes that strawberry tastes amazing, and sometimes it tastes sour, and sometimes it tastes other things. And so we recognize that in addition to just saying this is the food that you should eat, we also have to work on how we introduce foods, new foods to our patients, and making them lovely and tasty. And so we've had some opportunities to do that. And we'll talk about that in a minute.
We know that, and let me back up. When we were talking about the functional medicine labs or the deep dive labs that we do in our patients, it's really in part to identify some nutrient deficiencies that aren't traditionally tested in anyone, let alone in our population, because our population, the IDD population, largely gets undertreated and underdiagnosed for so many things. But we know that even mild nutrient deficiencies, vitamin D deficiencies, B12 deficiencies, B-folate deficiencies, zinc deficiencies, magnesium deficiencies, even mild nutrient deficiencies will affect brain function. Our brain, I told you, it consumes about a quarter of our total fuel requirement, but it only weighs 2% of our total body weight. So it's small, actually scarily small compared to how important it is, but incredible, as you know, incredibly important and incredibly a little bit greedy, a lot greedy when it comes to needing fuel. But it's because there literally are an unmeasurable amount of connections that happen between the cells in our brain, as well as how they connect and communicate with the rest of our bodies. So we know that even if you've got, it's like a ripple effect, right? You throw a little pebble in a pond, but there's this ripple that occurs. Same type of idea when it comes to even a mild nutrient deficiency can have far-reaching implications when we talk about brain function, and that can manifest itself as OCD symptoms or insomnia, so many different ways. So this is why, part of why we do our deep dive and why we care so much about the brain and why we care so much about foods. You know, in talking about foods, one of the diets that keeps winning awards, if you will, is the Mediterranean diet. You know, it's so confusing. There's so many diets out there. Like, should I do an Atkins diet? Should I do a keto diet? Should I do a paleo diet? Should I do a Mediterranean? Should I do a SAD diet? That's what we mostly do. The standard American diet is the SAD diet, and that's what the vast majority of our country eats. But time and time again, the winner is the Mediterranean diet. Why? The Mediterranean diet sources, in general, locally produced foods. And we know that when foods have to travel less distance, they have more antioxidants, they have more nutrients. We know that the Mediterranean diet tends to have a lot of fiber. It's got a lot of beans, a lot of vegetables, fruits. We know that a Mediterranean diet has healthy fats, like omega-3s from fish and olive oil. And so the Mediterranean diet, not only does it make our brains happy, but it also makes the rest of our bodies happy. And it actually, aside from helping someone who has OCD or anxiety or ADHD, it also helps improve longevity. So for those caregivers out there who are like, oh my gosh, I can't die. I can't, because who's going to take care of my kid? Pay attention, because the Mediterranean diet can help improve longevity. And it's pretty interesting. Of course, the greatest improvements in longevity are made when you start a Mediterranean diet, and that's just built into your lifestyle from when you're a little kid. But even people who at age 80 start adopting a Mediterranean diet, in general, it can add 3.5 years to life expectancy. They tend not to be just quantity of years, but also quality of years. So I would encourage everyone to maybe save this slide, and we'll teach people how to sneak, even for people with sensory issues, you can sneak some of this stuff into their diets. This is what a Mediterranean diet tends to look like. I don't think actually salmon is a Mediterranean. I don't think you get a Mediterranean Sea, but the point is, it's a healthy fish and it's got great omega-3s. But it's look at this. It's
a rainbow.
It's a rainbow. It's colorful and it's got some great fiber and some great antioxidants in there.
This is something that we can probably talk about for the whole hour.
Yeah, yeah. So we were privileged enough to go out to a conference. It just happened to be in Napa. That's not why we chose to go there. That was just one of the fringe benefits. But it was put on by Harvard, and everyone's heard of Harvard, right? Yeah. And the Culinary Institute of America. And it was, so I've been in practice. I graduated from med school in 1995. So easy to do the math. I've been in a position for 30 years. This is hands down best conference I've ever been to. And what it talked about is the importance, it was called Healthy Kitchens, Healthy Lives. And it talked about the importance of making healthy food choices. And what's happened is our country is almost bastardized what is good food versus what is not good food. Like some people think if they eat Pop-Tarts for breakfast, that's good because there's like some strawberry stuff in there. And isn't that a fruit serving? Or maybe chocolate milk is good to have for breakfast because it's dairy. And so this conference talked about the importance of reteaching the American population what actually is healthy and desirable versus what's not. And so there's a concept of teaching kitchens where literally we're getting down to brass tacks and we're starting from scratch and saying, forget everything you've been taught over your lifetime about what's healthy and what's not. We're going to start from the beginning, and we're going to teach you what's important and how to eat in a healthy fashion. So we actually need to be taught that. So they're cropping up all over the place, called teaching kitchens. Seems like I know how to cook. Why do we need a teaching kitchen? But it's teaching people how to prepare their meals, what to include in those meals, and they're for everyone. This is full disclosure, and I have permission to use this picture. This is my son. I have a special needs son, Nick, who he's on the ketogenic diet because of seizures, but he does a cooking class. His cognitive age is about the level of a 3-year-old, but Emily, who's his teacher, has purchased safe. See, there's like a knife there. It can't cut skin, but it can cut vegetables. And she works with him and teaches him how to cook. And he's really started becoming an active participant in the kitchen, not just eating, because he was very active with eating before, but now he's an active participant when it comes to making the foods and developing an understanding of, I might not have eaten this before because it's a little bit slimy, but you know what? When I mix it with other things, it tastes great. So my point in this slide is that teaching kitchens are for everyone, not just people from Harvard, not just people from the Culinary Institute of America, but for everyone, including caregivers, including group homes, including medical students and nurse practitioner students. It's not just exclusive to anyone. Actually, everyone would benefit from a teaching kitchen.
Yeah, and what we have found, at least when we discovered a new way through this conference of also how to get a food history and get an understanding of where our patients are. And the reason why we're spending so much time on this, because food is such an integral part of our patients' lives and such an opportunity for longevity for our patients. And quite frankly, in traditional medicine, this has been something that I had not had the privilege, and our current med students don't have enough information about. So this is why we're spending so much time on this. That even at the level of how much our patients are participating in acquiring their food, making the choice of what their next meal will be, knowing where their food comes from, like getting into the farms and understanding where their food is coming from, and then actually having time to prepare foods. We understand that our patients' families' lives are very busy, and taking more time out to just get a meal on the table can be incredibly challenging. But we're hopeful that everyone participates in our future teaching kitchens, so that you recognize the value of including your loved one in the preparation, including the choices of meals. We're hoping that that also happens at the group home level. I will tell you, our current experience has not been, while there is the perception that choices, that our patients have choice in their meals and are participating in it, that's just not our experience with our patients. And we really think that that's going to be a huge value in adding longevity to our patients, but not only longevity, quality of life, knowing that it will reduce their anxiety symptoms, knowing that it'll reduce their inflammation.
Less medications
required.
required.
And then our group homes don't have to administer medications and can spend more time on the fun part of eating and preparing together and bringing that community together. Our whole goal is a blue zone. And if you don't know what that is, spoiler alert, go to Netflix and see where you can see the next thing. So we mentioned specifically part of the HRSA grant. We're currently in our Movement is Medicine year. Muscle is medicine. And certainly what you pick to eat can help build muscle, right? Eating good proteins, eating good plant-based proteins that are part of that rainbow can increase that. But movement is medicine. And even if you use technology, wheelchairs, have other need for, or have decreased mobility, movement is still going to be a huge important part of longevity, of maintaining. I'll say that I coined the phrase, I want to coin the phrase, preserving the pivot, especially for our caregivers. You need your loved one to still be able to pivot so that you can continue to provide the care for them. And so that means that we have to maintain movement. It does mean that we have to get other people involved to help us. So we very much value our physical therapists, our occupational therapists, any one of our yoga trainers, our sports groups, you know, like Special Olympics, and I'll use that because that's a big one, but we have so many other sports groups that help maintain movement for our patients. So we will ask you every time, even just a little bit every day counts. And I think that's, oh no, that's not part of that.
So while Jen's getting our slides back up, just to talk about that slide movement, any amount. You know, before I came to RISN Center, I did a year of integrative medicine training up in New York City, and included in that was yoga training. And what we did was we went to Sloan Kettering as part of an internship. We went to Sloan Kettering on the oncology ward, and we were working with end-stage cancer patients who were in bed, they were on chemo, they felt horrible. And we would come in and say, we're here to do some yoga with you. And they were like, yoga? I have an IV in my arm. I'm so weak. I'm nauseated. I can't even move. How am I supposed to like get out and do a split or do a headstand or do yoga? And what we would say is, you know what, it's okay, any amount. You can do yoga with someone who's laying in bed. They can derive benefit from it. Any amount of movement is better than none at all. And it's a use it or lose it type of concept. So any type of movement that we can build into anyone's day is better than nothing at all. So that's why we say any amount is perfect amount.
And before we move on, I know I'm already on the artist medicine slide, but we're also looking at other technologies to figure out how we can track some of the movement, because some of it is challenging to, you know, oh yeah, I've been doing that, but how do we really quantify it? And we have a lot of really exciting tools that are out there. We have, you know, pedometers, we have things like the Aura ring that can really track what our movement. I know I forgot to wear mine today. I'm embarrassed. Actually, I feel naked without it. But we have other tools to measure our movement, our heart rates, you know, so we have opportunities to really track this. And I think that that's going to help us really understand. It's another data point.
Mm-hmm.
Kind of a functional medicine approach that helps us keep,
like a vital sign.
Yeah, to helps keep patients informed of their progress. And also, you know, kind of makes us feel proud when we hit that 10,000 steps or when we, you know, get to other parts of medicine. So what else is medicine? Community, doing things like art projects, doing things like music opportunities. What we know is getting out in nature, which movement can get you there, getting out with our community, both through sports, music, art, they actually enhance our health.
Going to the grocery store, you know, pulling food in there as well.
Yeah. So all these other things really are, how do we bring us together as a community to increase it? So recently we had a wheelchair ballroom dancing lesson. And it was a lesson that was as important to people who use wheelchairs as able-bodied participants, and maybe even more for the able-bodied participant, because then the able-bodied participants can recognize how capable our patients are, even if they use technology, how much they can contribute to joy, like listening to a good song. And we use music in our medicine all the time. When patients come for reproductive health exams, they're nervous, right? So we're like, let's pick your most joyful song.
Bring a playlist
to get this done.
Playlist for your pap smear.
Yes.
So you guys might want to adopt that.
Exactly that. So that's how we recognize. And listen, you know, our offices don't need to be so silent. You know, we all actually feel better. Matter of fact, our staff very much have asked for, can we play music in our office so that we can see it? Equally, we are starting to splatter our office with art from our own patients, art that we create together. So we have a future opportunity that's coming up to create a mosaic with people with different abilities and with our med students and our physicians. And we know that these community events not only add beauty to our spaces, but also just bring us joy when we come into work every day.
We're also bringing food into it, and that we're growing herbs. We got a hydroponic plant stand, and we're growing all different types of flowers and herbs and lettuces right in our office. So patients, if they want to, and everything's edible, including the flowers. So for those people with pica who are like, I'm gonna eat this, they can, it'll be okay. It's not a medical emergency. But if someone's, wants to explore and say, oh, I wonder what a basil leaf tastes like, we can encourage them to do that while they're in a safe space within our office. So we're pulling food into it, locally grown by the individual. So we know that you're more inclined to eat something if you grew it, produced it, cooked it yourself, especially if it's trying a new texture or a new flavor. So we're pulling that into it as well. Actually, we had done something several months ago where I brought fruits and vegetables in and brought my juicer, and we made a green juice and an orange juice and maybe a red juice. And the red juice, I think, had beets and apples and some strawberries, and the green juice, which we thought no one's going to want. But actually, some of our staff were like, I'm not going to drink green juice. It's green. I don't eat green things. But some of our patients, we just had it in like little shot glasses. Some of them who don't even eat vegetables and don't even eat green things, because they were there with us and we were like, cheers, let's do it together. And they're like, oh, that tastes really good. So it's kind of just doing an introduction to different modalities that people may not otherwise embrace. I don't do art. I'm not even a good stick figure person, but this mosaic, I'm all for that, because you can just,
You get your hands dirty.
Anyone can do any of these exercise, any of these modalities that we're talking about, and that's the beauty of it.
And the reason why we bring it into our office too, there are some studies that some pediatric hospitals had McDonald's attached to their facilities. And when they actually looked at the patient perception of whether or not McDonald's was healthy, they found that many patients and their families thought that it was. And we equally want to make sure that we're showing things that are healthy and that we do them too, kind of based on that study. So then plus it's pretty also, it's another art in our space, so that we can move from that. Mindfulness is even more important, and we all need this throughout our day. Again, we're bringing back yoga. Many of our patients are like, yoga is for old people, but again, it's a true story
For anyone.
because it adds longevity. If you can still do yoga when you get older, believe it or not, yoga can make sure you get older. And what we do for mindfulness in our office, we are blessed to have a really multidisciplinary approach to health. So when you come to RISN Center, and again, I think that many other practices are starting to adopt these support services in their offices. So social workers, clinical psychologists, nurse practitioners who have specialty in psychiatric care are also helping us bring mindfulness into our lives and our medicine, reducing stress, improving our access to some of our stressful procedures like a reproductive health exam, or a needle, or a blood draw, or a dental exam. So bringing in some support through mindfulness is really one of the other ways that we increase access to longevity and routine preventative healthcare, to check the checkbox for some of our traditional medicine, but also to take out some of the medicines from our traditional medicine so that we can use tools that don't require anything outside of us, that we bring it with us every day. And when we practice it, just like we practice medicine, when we practice this mindfulness approach, it comes to us when we most need it, right? So everyone thinks like, well, no, I've tried that. It doesn't work for me. It's because they're not continuing to practice it.
We actually did back right between the holidays, we had done a program for caregivers and their adult special needs children. And we incorporated all of this. We incorporated a music component where there were instruments that everyone could play. We incorporated art. We incorporated mindfulness in the form of chair yoga and also breathing exercises with bubbles. So we would have, the bubbles that you blow, we'd have someone dip their bubbles and take a deep breath and blow it out. And there's incredible value in that. I mean, even if you just do it 3 times, I feel like when I'm at a stoplight or if I'm, ready to have some road rage, like, okay, just take a few deep breaths. My son even knows that now. When he gets frustrated, all of a sudden we'll hear him go, whew. So he knows, he recognizes the value of deep breathing. And when you can incorporate that in creative ways, but that's a form of mindfulness as well.
And thanks, Gina. I love your
Yeah.
approaches, just to share with the
Very
group.
cool.
Sample size, which is sort of what we're trying to introduce in shot glasses that don't have alcohol. But these sample size opportunities, and I love your example of like Costco, where you
Yep.
go on a Saturday and get to try everything. We also have been privileged through the HRSA grant to bring on a dietitian who's helping us understand that and really show some of her creativeness. But we're hoping that we can do that more. It's the same way that, so part of with those food is medicine is really providing prescriptions for these wellness activities. So one of the best things that we introduced that came from our nutritionist, our dietitian, was think your drink.
Yeah.
And just thinking about, and again, I'm just going to use Gina's example of having water or having unsweetened iced tea, but using frozen fruit as your ice. And being able to think your drink, because we know it helps with everything that a lot of our patients suffer with: constipation, dehydration, obesity, right? Each of these things, once you just introduce thinking your drink and more water, and in creative ways like adding frozen fruit as your ice, which I love now. I think we're gonna have to have some. We're gonna have some
teaching.
have some of that in our office.
On that. So we know that neurodiversity, just the fact that someone has some form of neurodiversity can lead to increased cardiovascular risk. We don't have great data on this because this huge wave of neurodiversity that we're experiencing, not only in New Jersey, but also across the country. I saw most recent data that, just speaking for autism, the recent numbers are 1 in 31 people across the United States. In New Jersey, 1 in 29. That doesn't include a whole bunch of other disabilities as well. But we know that just being neurodiverse can lead to increased cardiovascular risk. Because we're not looking for the risk factors like we do in neurotypical people. These people tend to, not always, tend to eat a diet that isn't as healthy. They tend not to be as physically active. They tend to have high levels of stress. So that mindfulness component isn't there. There tends to be a lot of screen time. So all of these collectively can lead to increased cardiovascular risk. Now, do we know that this is going to correlate to increased cardiovascular events? So it's one thing being at risk for having a heart attack or a stroke. It's another thing for it actually to happen. So I suspect what we're going to see as our wave of autism, they're now in their early 30s, mid 30s, as they age into their late 30s and 40s, I do suspect, again, I don't have studies to support this yet, I do suspect that we're going to start seeing cardiovascular events, heart attack, stroke, happen at earlier ages. Another one of the barriers is sometimes they can't tell us how they're feeling. They have behaviors. So we're going to have to increase we're going to have to lower our threshold to think, oh gosh, they're having behaviors. Maybe it's from a dental issue, whether it's causing foot, maybe they're also having chest pain. They're at that age now. they've had high cholesterol for a long time, they haven't been eating well for a long time. Maybe they're having a cardiovascular event and they just can't express that to us. So that's adding yet another layer of complexity into the population that we suspect we're going to start seeing moving forward. And I like to, I need easy ways to remember things. That's just like, I don't know, that's just how my brain works. So I try to think of acronyms. So what I like is the acronym to dress for success. And the dress, the DRESS, stands for these words as I listed them there: diet, which we've talked about, relaxation and stress relief, which is that mindfulness component, that art component, that music component, the movement component, even the act of cooking. Well, for some of us, it increases stress, but for some of us, it can be a stress reliever. The exercise we talked about, and then improving sleep. And then we talked about the importance of community, and I think of it as support, because some of our clients don't want to be out in the community. Some of them have agoraphobia. They don't do well with social interactions, but they still need some form of support. And so instead of social relationships as that last S, which is, I would include social relationships in a neurotypical population. And that may be social relationships in the neurodivergent population, but it could mean just supporting them in the best way possible, giving them wings to fly instead of clipping their wings. And we need to start allowing our special needs individuals to become the best version of themselves by equipping them with tools to give them those wings to fly. And I feel like if we address all of these issues, we're going to help move them in that direction. We didn't touch a lot on sleep. Suffice it to say, a healthy diet that doesn't have a lot of stimulants, it doesn't have a lot of artificial sweeteners, a lot of sugar, a lot of additives, because we know all of those can be stimulating. Caffeine can be stimulating. That can disrupt sleep patterns, and then they're not sleeping well at night. So guess what? During the daytime, they are feeling sluggish. They don't want to move. They're having behaviors. So sleep is incredibly important. We could do actually a whole talk on sleep.
Yeah.
But that's something that tends to get ignored, and we're starting to take a deeper dive when it comes to sleep as well, helping identify when our individuals might actually have sleep apnea, and finding pulmonary colleagues, sleep specialists who are our colleagues who are willing to sit down with our patient population and say, look, I know you got sensory issues. I know a CPAP mask isn't going to be that fruitful, or if we can even get the sleep study done, but let's think outside the box and how can we address these sleep issues? So anyhow, when I'm thinking about a holistic approach to health, and you can even take the longevity part out of it, right? We're more interested in quality of life. We're more interested in quality in the years rather than the quantity of the years. But if we get quality and quantity, then that's an added bonus. And that's not just for our patients, that's for our caregivers as well. We're not expecting that everyone brings this all these check boxes and say, okay, we need to do this, 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 and this, because that's not how we operate either. It's a journey, and the journey isn't an A to B journey. It's an A to B to C to D. And so any amount, just like when we were talking about movement, how any amount is better than nothing at all. That's how it is with everything we've talked about today. Any amount is still better than where we're at today. So you've got to start somewhere. Just choose one small hanging fruit to work on and tackle that first. And it becomes easier and easier. The more low hanging fruits that we're successful with, then we can work on to the bigger items.
Yeah, and that support piece for us in medicine is so important, because the reality is we wish we could see you every week. But in order to be able to do the traditional work that we do, we require to have all of our community partners really help that. So we start with identifying some of the opportunities and then giving you prescriptions, but we can't check in every week. So we really require our PTs, our nutritionists, our support personnel, our day programming personnel, our parents, they're our
Support
peers.
coordinators.
Yeah, the support coordinators really to help us on this journey, because we recognize that even when we give you one prescription, like drinking more water, we can't check in every day to make sure that that's happening. But we equally recognize that, especially if we're seeing a young adult, a 21 to 22-year-old, we don't think that you're gonna get to the end of the game by being successfully healthy after 3 months when we follow up with you. So recognizing that that even us as physicians need to phone a friend and use our support systems to make sure that in this journey, you're helping us all achieve those goals to wellness too. Because we care coordinate about you. And so with that, just know that we are growing. We just mentioned that we're going to be in Cumberland County starting in July. And certainly if there are any among you who are looking to work with us, this is an opportunity that we wanted to just point out. But we also wanted to leave some time to take any questions if you have any. I know we're just about out of time, but we're happy to stay on and address any questions or concerns. Oh, yes.
Thank you both. You're both just wonderful. I really love the approach that you take in your presentations, right? It's more of a friendly conversation that you're having with all of us. And the two of you are just fabulous together. I say it all the time, but it's true. So we do have a few questions coming in, and I'm just as excited to see that we have some great resources and suggestions, right, being shared by others in the chat section. So that's fabulous. Again, if anyone has a question, please feel free to use the Q&A box. It's an icon with a question mark in it. Click on that, type in your question. If you can't find that, use the chat feature that's been popping up on your screen. By all means, we will take questions in either sections. The first question is, my 21-year-old son has profound cerebral palsy and some medical complexity as well. Could you use a functional medicine approach with someone with his needs?
Yeah, you want me to speak to that
Please.
one? Yeah. So lots of issues or opportunities come to mind when thinking about cerebral palsy. So a lot of our patients who have cerebral palsy have problems with spasticity, and that leads to pain, and that really impairs their quality of life. So we tend to use, there are the usual medications like baclofen pumps, lorazepam, different things, but magnesium also is a wonderful supplement to help improve muscle tone, to help with spasticity, to help with muscle cramps. CoQ10 also is something that your body, it's a substance that your body generates that helps support muscle function. Again, spasticity is an issue with cerebral palsy. So we may say, you know what, have you tried a CoQ10 supplement? And maybe you need a higher dose. Maybe your body doesn't regenerate CoQ10 the way it should. So instead of doing 100 milligrams, maybe we do 200 milligrams. So those are just one small example when it comes specifically to the spasticity that we could use in someone who has cerebral palsy with significant levels of debility.
Yeah, and we also have partners at Rowan who use alternative medicine, so acupuncture and OMM, which I think that has not been so widely used because RISN is now integrated in the School of Osteopathic Medicine. Those approaches, we really are not just to go right to spasticity management with medications or with injections, but really to use some more osteopathic approaches to movement with these, which we know can help with sleep. We know can help with bowel movements, again, which traditionally have been challenges for people with movement challenges.
I actually have a research meeting at 7 o'clock tonight
About
with that department.
Yeah, I mean, that department especially has been working with us quite well.
Yeah.
And so we're hoping that we can continue to do some evidence-based research on how do we introduce this to everyone that can help it.
We want to make it standard of care.
Fabulous. And then we have another question that came in. It is really specific. I do want to preference the next question by saying right, we're not here to treat, diagnose, but I also don't want to be dismissive that someone does have is inquiring. Do you want to
Correct.
look at
I
that
can
first?
address that. Yeah.
Perfect.
So, so a question specific about changes in behaviors that are pretty abrupt. And really what I just want to say to that is behavior is communication. And unfortunately, sometimes our traditional medicine approaches, like just getting an X-ray, and then saying that nothing's wrong, doesn't always get us to the right answer. But what I would say is that it tells me that as a caregiver and as someone caring for a loved one that has these changes in behavior, you have to be more vocal that this is different and it needs a next level approach, including, being able to provide some support for constipation, which we know is really challenging for our patients.
So many, we see so many GI issues and we know that the gut communicates really readily and like symbiotically with the central nervous system. So when you have something called leaky gut, or when you have an imbalance between good bacteria and bad bacteria, that can affect literally every other aspect of how your body functions. And so when we see someone with a behavior change, one of our questions might be, have you been on any antibiotics recently? Did the behavior changes correlate with that? Because it could be that there's a dysbiosis, an imbalance. Maybe you've got too much yeast in your gut. Maybe you've got too many bad bacteria, not enough good bacteria. And sometimes we fix that.
Yeah.
And that's something that's a low hanging fruit.
The other thing that's really valuable to us is continuity. So while we do value our emergency medicine physicians and our urgent care physicians, they often don't have the connection that that we really need to have that facilitates communicating with your primary care provider. And I will tell you, that's a big barrier, especially when we leave the pediatric system and enter into the adult medicine system. And so that's why finding a primary care doctor, because I will tell you the subtleties of this is not my friend John, this is not my patient Susie, and having a relationship and that. So while I know these abrupt changes maybe sometimes do warrant us going to the emergency room or to urgent care to get their needs met, getting back to your primary care doctor, so that you can, and maybe more than once. It is unfortunate that the squeaky wheel gets the attention, but sometimes, especially with abrupt changes in behavior that you articulated here, it really requires being a little bit squeakier with your primary care provider to look at what the next step is.
And the answer shouldn't be, I don't know. The answer should be, and this is not a bash to other primary care providers, but the answer, in my opinion, should be, I'm not sure yet. We're going to keep looking. And seeing a comment here about sleep issues in people with autism, huge issue. Multifactorial, and I see, someone's mentioning they had a sleep study done, 0 REM sleep, kind of like me some nights actually. But yeah, a whole lot of different issues with that. We like magnesium, we like passion flower, that can help with sleep. So a whole bunch of different options, both traditional medicine and integrative functional alternative medicine.
Yeah, magnesium helps you naturally release melatonin. So that's another reason why we like it. It also does help facilitate or does help with constipation, which is such an active problem for our patients. And there's some other non-traditional things that unfortunately haven't been studied. So like this is very off-label, but hemp bombs or CBD, some people have found them to be valuable. I wish we studied them more so that I could give you a better evidence-based response to those non-traditional medicine approaches to sleep. You know, but again, we are open to looking at those non-traditional things too and working with our patients, and hopefully your physicians are too. There definitely are other resources out there that are not traditional medicine that can help guide with some of these some approaches, and food is a big one of them.
So we have another specific question coming in, if you want to take a look at that first.
I think that's on
Dr. LeCompte just put someone had asked for our
Your website.
no, yeah,
Oh, no, that's nothing
I think
there.
on the chat.
Is it on the chat? Okay.
Provide high-level approach to supporting young adult with diagnosed autism, epilepsy, food refusal, weight eating. We have a lot of people with ARFID. I know one Dr. mentions they don't diet. Yeah. So I think that I was the one talking about diet as it relates to epilepsy. So the ketogenic diet actually has been well studied. It's one of those, it's not I think it's starting to become considered mainstream for those parents who want to take it on. But my son has been on a ketogenic diet, really strict ketogenic diet since 2003, where at one point 90% of his actually 94% of his calories were from fat. So yes, he was drinking olive oil and eating butter. But it's incredibly helpful. We've lightened up on that. He doesn't have to drink olive oil anymore, but he does still eat butter with each meal. And so we know that some diets, like the ketogenic diet, does help stabilize the brain. So, and again, you can get creative with that and find something that I know in this particular case, your child has food refusal, avoidant eating. I feel like we think outside of the box, like people who need fiber. It's like, okay, but they won't eat beans. So what we started doing and with some of my patients is the parents will puree it and like mix it in with the mac and cheese. So, and it's white beans, so it doesn't change the color of the mac and cheese. It really is flavorless, but they're getting some natural, sorry.
You're back.
So, yeah, so I feel like everyone has very specific instances when it comes to their child. And I feel like it's finding someone who's willing to think outside of the box and work with you until you find something. A lot of times it's trial and error.
Yeah, and we also ask for ABA therapy. So it depends on, unfortunately, the age of your child. So under 21 has a lot better access, but we do have ABA therapy. ABA therapists who can help with food refusals. So honestly, our clinical psychologist has been helping us in understanding how do we introduce new foods to some of our patients. And sometimes it's just about putting a new food in the same area as a preferred food item. And again, not even asking them to bring it to their mouths, but similar to that food prep, introducing people into the prep. So having them prep a new food, but maybe not eat it, can also be very helpful. Our speech therapists do help us with folks with some oral motor challenges as part of food refusal. But here's the other reality. Sometimes this food refusal has been because, similar to medical trauma, it hurts when they eat or it doesn't feel good and they can't express that or tell us that. And that's where some of these alternative functional medicine approaches, like doing stool studies, can really help us understand why people are refusing. Because what happens is once that inflammatory response or that hurt goes away, the behavior of that connection of the hurt doesn't. And that's why the ABA therapists are so helpful in helping us show our patients that it doesn't hurt anymore. And then one of the things that our clinical psychologist is also helping us approach is a lot of our neurodivergent patients don't get a sense of fullness.
Yeah.
They don't know how to identify what is that feeling, even though we know they have to be there, right? Some of them are actually throwing up to the point of fullness. And so we have to start to introduce signaling outside of their body so that they can start to recognize what that body signal is. We haven't found the answer to that, but we're starting to explore that. And that, I think, is a big part of food refusal.
Fabulous. And if I could share just a quick personal experience, so we've had many conversations with Dr. LeComp about healthier eating, and bringing in some fruits and vegetables, which is not always the easiest. And I appreciate you both for recognizing that today, that right, there is no failure on the parent from, for your child not being willing to even try fruits and vegetables. But I feel like we are starting to make some progress, and it's
Any amount,
right,
Melanie.
for a kid who won't eat carrots, but he'll eat a carrot cake really quick, right? We have to find a way to make a healthier version of that. And I triple the amount of carrots that go in. We're putting in the chia seeds in there, and I'm putting in raisins. Not that they're the healthiest, but we're incorporating
Natural sugar, no added sugar,
right,
but natural sugar is a win.
we're blending down, right? Dates, soaking in hot water, blending them down as a natural sweetener and things such
I
as
think
that.
we need that
And
recipe for our teaching kitchen.
But it's funny to see, and I'll introduce that. And again, this does not work for everyone's child, but it was actually a suggestion that I received from another parent that served us well. And we did that. He loved it. And the next time I actually had him make it with me. So he was seeing what was going in the thing that he loved, right? But we took steps to get there. And I think, much like what these families and professionals are doing today, asking their questions in the chat, getting some of these resources from you both, the experts in the field, and also from others who are also having lived experiences with their child of what has worked, and we take bits and pieces and figure out what works for our loved one best.
So I'm putting back your last slide so that you have your information.
And there's one more.
So
after.
on this slide that the doctors are kind enough to put back up, you're going to see we have a sign up QR code for the newsletters that the Community Living Education Project puts out. We share special announcements of information sessions, such as the one that we're doing today, as well as sharing resources from other agencies. We do not gatekeep, right? We want everyone to know all resources out there. And if you would be so kind as taking a quick snapshot of this QR code, it is going to be an extremely brief evaluation. It takes about 20 seconds to do. It's information that you provide us that allows us to better serve the community moving forward, specifically to having topics relevant to your needs. So with that being said, we do have another, our last scheduled webinar will be next week, and it's going to be part 2 of this medical series with the Rowan-Virtua RISN Center. It's the next session, I believe, is May 7th. That registration link is in the chat, and it's for overcoming barriers to healthcare, reducing anxiety, and enhancing access to routine medical procedures. So it will complement this session beautifully. We hope to see you all there. Again, we are going to have a copy of the recording sent out over the next week. And if you have any questions at all, you have my contact, and you have the RISN Center website that the doctors shared in the chat section. So yeah, if you want to stop sharing, unless there's another slide, feel free.
Nope, that's it.
And I want to take this time to say thank you so much. Always the greatest of pleasures working with you both. So I hope that we see each other soon, and we wish everyone well.
We will.
Thanks everyone for your attention.
And staying on. Yeah. Thanks.
Thanks.
Talk soon.
All right, bye-bye.